and at the NIH. So the notion of mHealth strategies may improve our odds, not only to find treatments, but maybe to enable us to come up with better designs for our clinical trials and to reach out to more people in them. So here's some of the confounders of our clinical trials. First of all, we don't know very much about what our patients do day to day. We don't know how much they exercise. We don't know how much they walk. We don't know how much they use their upper extremities. And yet we're trying to come up with interventions to improve those uses. People with chronic diseases, chronic lung disease, asthma, congestive heart failure, we don't really know what their level of activity is, and yet that could be an interesting biomarker of what the state of their health actually is. So we go into trials not knowing much about what people were like before. Now we dump them into a trial, and we're going to look before and after. But we don't really know if our before is a stable baseline. Then it becomes really hard to recruit patients. You saw how many trials are going on, and many of these are across the same diseases. So there aren't that many people out there who might participate, and many people who participate live too far from a center that might be doing a trial. And we also have trouble retaining patients in our trials, and that's because it's a burden for disabled people to come to a university site and have tests done and then go home, especially if you're at UCLA and have to get into West Los Angeles during rush hour. So we need a better way to reach out to recruit patients and maybe do that in a kind of tele-recruitment fashion, or use sensors to be able to follow them and keep them from having to come in to clinic sites as much as possible. We're also unable to monitor compliance with the instructions that go along with that clinical trial, or even in daily care. You know, are you doing X, Y, and Z